All right, welcome everyone. Thanks to those who are joining on Zoom and those who are here in person in 5200. We're really excited to have Tyler here speaking to us today. We're co-hosting this seminar from the CLIP Center, which is the Community Leadership and Innovation and Practice Center. We're doing things all about pharmacy and shaping the future of outpatient pharmacy practice. So if you have any questions about the great work that our faculty and staff do in the CLIP Center, please let me know. We can get you connected on our grant work, our teaching, our service. Happy to talk more about that. And then, of course, PERU is also the co-sponsor. We're hot off a really great retreat. If you were at the afternoon sessions yesterday, I got a lot of new ideas, made lots of new connections. So thanks, Lucas, for leading that. And I'll hand it to you for intro.
Hey, yeah, well, thanks to Luke for co-sponsoring the seminar with us. And yeah, we're in a great mood at PERU, had a really wonderful retreat the last 2 days. And we're thankful that Tyler Varisco, who's going to be speaking today, was willing to join as an advisory board member for our first annual retreat. I've known Tyler for several years. He was an assistant professor at the University of Houston. I actually met him first as a student. I was brand new faculty at UT Austin, and he was in the PharmD program there. So he progressed at Houston through the PhD into a faculty role. And I came here to Pitt in December, and Tyler officially yesterday started as the director of the pharm program with my old crew at UT Austin. Very gracious of him to spend his first 2 days on faculty at UT Austin with us in Pittsburgh, gracious of them to allow it. So thank you, Tyler, for being here and for speaking today about a really critical issue related to lack of access to medications for opioid use disorder in pharmacies, and some of the work Tyler's been leading with funding from the Foundation for Opioid Response Efforts to try to address it in a meaningful way.
Can you guys hear me? Is this on? Awesome. All right. I'm going to try to stand in a spot where the people on Zoom can sort of see me, but I also want to be able to see the room. So thank you all for being here this morning. I'm excited to talk about a little bit of our recent research on engaging multiple stakeholders in promoting better access to care for patients with opioid use disorder. So we're going to kind of start off with an introduction to stakeholder engaged research and really begin to lay out some of the common pitfalls that could be, I guess, ameliorated by including multiple different perspectives in research in the health services field. We're also going to talk about 3 projects that my team recently completed that apply varying stakeholder engagement and key informant techniques to bring new perspective to substance use disorder treatment. So we're going to start with a graph that I think many of you are very familiar with. And this is, I guess, projected mortality from opioid overdoses going back to 2015. And I chose this version of this graph in particular because I really do think that 2015 is when things sort of get interesting. Oh,
Thank you.
Okay, let's see. I think my clicker may have killed my clicker. Let's see.
Hit escape to get them back.
Awesome. Well, oh, okay.
Well, they're better up there.
We're good. All right, we're good. I think things really do begin to get interesting in 2015. So in 2015, we were observing increases in mortality related to prescribed opioids. And the natural response, I guess, from regulators was to make prescribed opioids harder to get. And so there was this massive push to really rethink the scheduling, the DEA scheduling behind opioid products. And the DEA sort of zeroed in as hydrocodone as a very highly prescribed opioid product and moved it to DEA Schedule 2. Now, I was practicing as an intern in an independent community pharmacy at the time, and we had these 1,000-count bottles of hydrocodone. And overnight, we now had to treat them as a Schedule 2 controlled substance, meaning that we now had to back count them for every time we dispensed 14 tablets. This was massively frustrating. We also had to make room in our safe to store these giant bottles, so we ended up actually having to buy a new narcotics safe. There were all sorts of workflow interruptions that came from this schedule change that I don't think were considered at all when the DEA made this decision. granted, pharmacist workflow is nothing, right? If we are seeing consummate improvements in mortality, but as you'll see in a minute, we certainly did not. And at the time, I went up to one of my faculty members, who's actually now, as of yesterday, my department chair, and I said, Dr. Barner, we are seeing all sorts of changes in the way that we practice. I would love to survey pharmacists about how this is impacting them. So we sent out a survey to really look at some of these workflow changes. But there was a scale on that survey that, looking back, I think was very, very important. And that scale essentially measured pharmacists' perceived changes to their patients' health and safety as a result of this DEA rule change. And what we found, and sort of ignored at the time, was that about 40% of pharmacists felt that this would either not improve or negatively impact the health and safety of their patients. And the majority of pharmacists actually felt that this would either have no effect or would be detrimental to their patients' pain management therapy. In retrospect, I'm confident that these pharmacists were correct, that this was not a positive change overall. It did not prevent mortality, and in fact, it was detrimental to patients with actual pain. So moving forward, we began to see continual increases in opioid mortality, except we started to see shifts in that trend, where we started to see more and more overdose deaths due to illicit opioids or due to fentanyl, and the CDC kept pushing. And in 2016, they released their opioid prescribing guideline. And I put guideline in parentheses. I have very little respect for this guidance, if I'm going to be entirely frank, the 2016 iteration. This guidance contained almost no evidence-based recommendations. It was all expert opinion. And they proposed a series of risk mitigation strategies, including urine drug screening for patients with chronic pain, really harsh restrictions on acute opioid prescribing that led to a lot of patients being untreated for pain after surgery. And in addition to that, one of the most troubling things about this guidance was a lot of those recommendations made their way into statute. And we began to see states and payers restrict the amount of opioids that could be prescribed to a patient after surgery or could be prescribed in the setting of acute pain. What differentiated acute and chronic pain was not well defined in this guideline, and we saw a lot of deleterious changes to patient care. And that, I think, was very well reflected in the changes in mortality that we began to see over the next 8 years. And in 2022, the CDC sort of issued their mea culpa, and one of the lines in the 2022 guideline essentially stated, we never intended for these recommendations to make their way into law, but they certainly have. And in 16 states, we saw very penal provisions put into place that really restricted access and took those decisions away from physicians. More than anything, though, we began to see this phenomenon where our healthcare workforce really thought more about the administrative risk of providing care than the clinical necessity of care. This is never a decision that we should have our providers make. We need to remain oriented on the clinical and sort of weigh that with the administrative risk and with the risk of regulatory action. But at the same time, we cannot let administrative risk outweigh clinical necessity. And this isn't just my opinion. This is very much so reflected in data. So this was an analysis we did in data from the Texas Prescription Monitoring Program, using data from the years 2016 through 2019, I believe. And essentially, we paired prescription drug monitoring program queries with prescription drug monitoring program reported dispensations. So we could essentially determine, based on the provider and the date that a patient was searched for, what drug was being searched or what prescription was being queried in the PDNP. And what we found at that time in Texas was that pharmacists were 1.4 times more likely to query a prescription for buprenorphine than they were a prescription for codeine, and physicians were 2.2 times more likely to query a prescription for buprenorphine. We were seeing more oversight for the medication that we use to treat opioid use disorder than we did for a commonly misused opioid, at least in the state of Texas. We invented codeine misuse, lean, chopped and screwed, like city of Houston, where I'm from. We are the codeine capital of the world, and we're quite proud of that. But at the same time, we were seeing more scrutiny for patients that needed treatment. And a lot of that comes down to this idea that I am here to prevent misuse and diversion. What I think is really troubling, though, is that this pattern of decision-making sort of permeates through the entire policy and administrative chain. I did not invent this figure. I don't take credit for it. I did make it more simple for a PowerPoint. But this is one of my favorite papers from Heather Cooper and Trish Freeman at the University of Kentucky. And they really sort of were one of the first groups to try to substantiate how pharmacists make decisions for patients prescribed controlled substances. And their thesis in this paper that they derived from a series of focus groups and interviews was that really that decision sort of starts at the bench where the pharmacist is looking at it, and they were looking at it from the perspective of all of these levels above me are going to come down on me if I make a decision that provides care to this patient. And so it starts there. And at the heart of that is some stigma toward people who use drugs. I'm not denying that, but there is weight from the regulatory infrastructure upon that pharmacist in that moment. But another thing that I think is worth thinking about is that this also sort of goes up the chain, where we have pharmacists who are making decisions at the bench. They trickle into district management, where they have more interface with the DEA, where they have more feedback with the, or interface with the State Board of Pharmacy. And then some of those people will continue to move up the chain and will move into policy and will move into administration. And so this is this sort of back and forth between the bench and the regulatory level that makes it very difficult for pharmacists to prioritize the effective care of patients with substance use disorder or prescribed controlled substances. As Lucas mentioned yesterday at the PERU retreat, there's an entire book on this. Liz Chiarello wrote a great book called Policing Patients that really goes into these decision factors and kind of traces back the history of how we have made the pharmacists the police and made them make decisions that oftentimes leave patients out in the cold. I would recommend that you read it. And in terms of sort of where my current research is, this is really taken away from the actual solution here, which is addressing underlying substance use disorder and addiction. And in particular, I think that there's one drug that we could do a better job of promoting access to, and that is buprenorphine. And I think Dr. Hill would agree with me on that. But buprenorphine is a really unique medication for opioid use disorder, and that it is a partial opioid agonist, meaning that it carries very little risk of euphoria. Not that we should be concerned about risk of euphoria necessarily, but it also carries very, very little risk of respiratory depression and overdose. And in fact, only about 2.7% of all overdose deaths involve buprenorphine. 97% of that fraction will include another substance, usually a benzodiazepine. So this is a very safe drug that independently carries very little risk of mortality. And because of that, because there is so little risk of death, it is regulated as a Schedule III controlled substance. In addition to that, when buprenorphine is diverted, it's usually diverted to meet the treatment needs of patients who are having a hard time getting into treatment. So the diversion risk, especially for recreational use, is relatively low. This is a very safe drug that should be widely available. And it's unique in that it is the only medication for opioid use disorder right now that is available in all community pharmacies as a prescription from a physician. The problem is that patients have a really hard time accessing buprenorphine. And we'll kind of get into some of the availability side issues later on. But I think part of the reason that patients have a hard time accessing buprenorphine is because so many of these patients are not accustomed to dealing with the regulatory and stigmatizing environment that exists in community pharmacies. This is another study that we did a couple of years ago where we actually found that patients who were prescribed prescription opioids prior to initiating buprenorphine were actually significantly more likely to remain in treatment. And I think there are physiological reasons for that, in that patients who are using fentanyl or higher doses of synthetic opioids oftentimes do not respond well to low doses of buprenorphine and require more buprenorphine. But in addition to that, I think it's important to remember that the data for this study kind of predated our recent influx of fentanyl. This, I think, ended in 2018. But in addition to that, patients who are prescribed prescription opioids prior to initiating treatment are used to going to a pharmacy and dealing with all the bullshit, pardon my language, that's the only way to describe it, that comes along with that pharmacy encounter. So having some administrative tolerance and understanding how to navigate a pharmacy, I think really does help these patients remain in access to care. In addition to that, these patients know where pharmacies are and have a relationship with a pharmacy. And what we know is that half of all pharmacies just don't dispense buprenorphine. I've really benefited from the fact that Lucas did all these arduous audit studies. I'm glad that I didn't have to. Thank you for calling all these people. But at UT, they called approximately 5,000 pharmacies in 11 states and found that only 2,406 of them were actually able to dispense a 1-week supply of buprenorphine naloxone. So this medication is just not available. And so if you don't know how to navigate and find a pharmacy, you're less likely to be able to fill a prescription. And if all of the pharmacies are denying you, that certainly makes it harder as well. There's some more recent work that kind of looks at state-level variants and chain-level variants in buprenorphine availability. This was published by Scott Weiner in the Journal of the American Medical Association. And what they found is that actually that HEB, which is a grocery store in Texas and probably better than Giant Eagle, I don't know if those are fighting words here, but if you said something was better than HEB, we'd have a problem. And anyway, HEB was more likely to stock buprenorphine than any other pharmacy chain in the nation. And I saw that and I was like, I love HEB. But then I was like, why is that? That's really, really odd. And I think some of that comes down to the way that HEB has sort of been spared from recent settlements against pharmacy chains and pharmaceutical distributors. So as many of you are aware, we have seen a rash of opioid-related lawsuits that involve multiple states against the nation's largest pharmaceutical distributors and pharmacy chains, excuse me. And we've seen billions of dollars in payouts, and this has sort of led to impacts across the supply chain. And one of the most adverse impacts was in an attempt to offset some of their financial liability related to these lawsuits. The nation's 3 largest distributors, Cardinal, Bergen, who is now Cencora, and McKesson, sat down with the Department of Justice in 48 states and entered into an injunctive relief agreement that essentially provided provisions for how pharmaceutical distributors should detect inappropriate orders of controlled substances. And if you read this agreement, which I have, and I would recommend that you do so if you have an interest in this area, you'll notice that they call out several unusual formulations that should be regulated with increasing scrutiny or with increased scrutiny. And one of those formulations is buprenorphine without naloxone, which I'll refer to as buprenorphine monoproduct for the rest of this presentation. But if you read further into the agreement, you see that there are provisions in there that drug products should be regulated within family. What defines a family is sort of left up to the individual distributor. So if you are, one distributor and you've got an independent pharmacy that has a customer, you might decide that for that customer, a drug family that includes buprenorphine is all buprenorphine products. And so if they cross their monoproduct threshold, you're going to cut off their distribution of all buprenorphine products for the rest of the month, leaving patients that fill after the 16th of the month without access to buprenorphine. That's problematic because an interruption in pharmacotherapy for opioid use disorder, even as short as a week or so, increases risk of mortality by a factor of 9. And so this has had deleterious impacts on buprenorphine access above and beyond sheer availability at the pharmacy level, because even those pharmacies that are inclined to dispense are now regulated out of dispensing buprenorphine. So why is HEB so much more likely to stock buprenorphine? Well, they didn't get sued. So Ken Paxton, our state's attorney general, who is a colorful person who has had some personal issues, Ken Paxton, his office bragged about their settlements with CVS and Walgreens, but they never went after HEB. And to my knowledge, nobody has. And I think that a large reason that is because HEB, first of all, operates in a single state, the state of Texas. HEB is well loved by Texans. And if Ken Paxton sued HEB out of business, he would never get reelected again. So sparing this chain from these settlements has allowed them to continue to provide care. And from speaking to HEB pharmacists, they're very motivated to meet the needs of patients with substance use disorder in their communities. And that's how they should be. Now, hopefully the money from these settlements will have some positive impact on our ability to provide care. We're seeing disbursements of abatement funding. I have questions about oversight, but Texas has done a decent job of allowing communities to call the shots to some extent, but also allowing some of those funds to be sort of centrally accessed for projects in rural areas, especially. And one of the biggest problems that we see is that if buprenorphine is not available in the majority of all pharmacies, it's even less likely to be available in rural pharmacies. So this is an anecdote from a focus group that we did with pharmacists across the state of Texas. And we had a pharmacist from Nacogdoches, which is a really small county in the eastern part of the state. And there's only 9 community pharmacies in that county, serving a population of 65,000 people. Only 2 of those pharmacies are independents. And this independent pharmacist said, look, I want to dispense buprenorphine, but I can't. I have hospice contracts, and I've got to dedicate my opioid dispensing to those hospice contracts, because if I don't, I'm going to lose those contracts, and I'm going to be unable to keep my pharmacy open, essentially. And so she had to make a decision. And that decision came from this injunctive relief related need to triage your dispensing and to essentially choose who gets your opioid allocation this month. This pharmacist felt that it was better served her pharmacy to fill those hospice contracts. And I agree with her, because that's what's keeping the lights on in that pharmacy. And if she goes out of business, we lose a critical access point for patients across that county. It's a difficult decision to make. Unfortunately, we see pharmacists have to make decisions like that every day now. There is some stigma here too, but again, I think some of that stigma comes from the risk of regulation and from the messaging that these pharmacists get from the State Board of Pharmacy and other regulators. But in the same focus group, which is focused entirely on buprenorphine dispensing, we have a pharmacist, I think Lucas may have moderated this focus group. We had a pharmacist that said, just kind of out of the blue, you know, these people, they're going to want needles. And they're going to come up here and they're going to want to buy insulin needles. And what if I've got a 17-year-old girl working at the register? And what are people going to think about this 17-year-old girl selling needles? And it's like, okay, that's a really far-fetched scenario. But at the same time, they really do think about what their community values, and they reflect that in their care. So part of our job as researchers is helping them to understand that our communities do value safe and accessible treatment for substance use disorder. All right. And, you know, this is all fine, right? Because we have guidelines, right? We have guidelines that advise on how patients can better access treatment for opioid use disorder. One of those guidelines is Tip 63. I apologize for the blurry image. SAMHSA does not prioritize graphic design because they barely have enough money to do anything, especially now. But, you know, within Tip 63, there are great sections on community-based strategies to improve access to care. And surely those strategies include access to medication in pharmacies. They don't. So in the most recent update of Tip 63, which came out in, I believe, 2020, there's this line that has always vexed me. Any pharmacy can fill a prescription for sublingual or buccal buprenorphine formulations. That is not true. We all know that to not be true. And I brought this up with a pharmacist who works for SAMHSA, a guy named Navind Odit, and he was like, that's not in there. There's no way that line's in there. And I'm like, that line is definitely in there. And so now I'm happy to announce that in the upcoming revision of Tip 63, there are 2 whole pharmacists on the expert panel. And we really think that we've made a positive contribution to depicting the access climate. And I'm saying that not to, you know, let you all know that I'm on the expert panel, which is really cool, but I'm telling you that because I think that there is a broader acknowledgement that we need to make sure that all stakeholders are at the table to represent the unique needs of their practice setting. And I'm happy to announce that SAMHSA has decided that that is the appropriate course of action. So that was a pretty bleak picture. What kind of went wrong here? Well, I think the entire sort of administrative side of the US overdose crisis comes back to this idea that we have sort of let one party at a time steer the direction of decision-making in care. From 1995, when we got the beloved OxyContin phishing ad, all the way through 2015, that was the manufacturers. We have sort of let the manufacturers freely sell terrible evidence and encourage the wide prescribing of opioid medications. That led to some issues. And then we saw a massive pushback on that, where from 2015, sort of to 2020, but sort of till today, I really had a hard time picking an end date there. We really began to see some of the enforcement and legal entities begin to steer clinical decision-making. And that entire time, we've really had very limited input from patients and providers in a substantive way, let alone community-based organizations and the people that are actually doing a lot of this work. And the whole time, we've never really thought about the impacts here. We've sort of reacted to the policy pendulum. All right, there's a lot of opioid prescribing, make opioids harder to get. Okay, opioids are too hard to get, let's rethink pain and addiction. And it's always sort of been secondary, right, to the actual impact. And so we never really tested these assumptions or worked through these assumptions. And there appears to be this overall fulfillment of Newton's third law here, that for every action, there's an equal and opposite reaction. And I swear to God, that is the only thing I remember from high school physics, but it holds up really well in this circumstance where it's like the policy pendulum always swings back And unlike anything Newton could have predicted, when it swings back way harder the other way. That reaction is almost always stronger than the action that caused the pendulum to swing to begin with. And that's kind of where our recent work comes in. So given the dearth of guidance for pharmacists on how to navigate this regulatory and clinical climate, we had the idea to create a practice guideline for community pharmacists to help them make dispensing decisions for their patients with opioid use disorder. And we went to the Foundation for Opioid Response Efforts and asked them for funding to do this. And I was really surprised that they agreed that this was a good idea, and they agreed that it would be okay for me to do it because, like, I'm a assistant professor with no network and very little research experience at the time, but they seemed to really like the idea and gave us a ton of access to their experts and people to help us. We were also able to form a partnership with the National Association of Boards of Pharmacy and the National Community Pharmacists Association to execute this work. And our idea was to not only cover clinical territory and interpret it in a way that pharmacists could understand, but also to provide direct guidance on some of the regulatory and administrative aspects of care that are just not covered in other clinical practice guidelines. And to do that, we knew that we wanted to not only include physicians as experts, as is often the case in most practice guidelines, we wanted to include regulators, we wanted to include folks from boards of pharmacy, we wanted community pharmacists, psychiatric pharmacists, we had a pharmacy technician on our panel, and we had representatives from drug distributors and from the DEA at the table as well. And before we even started, and this is kind of point number one, we wanted to go directly to pharmacists who are making these decisions on a daily basis. And there are great community pharmacy practice networks now. I appreciate the work that these groups do, but oftentimes those are our most motivated pharmacists, right? That really want to adopt new programs and do real things. I wanted your average run-of-the-mill bench pharmacist from Walgreens who was just getting drawn a paycheck. I wanted to talk to them about why they weren't dispensing buprenorphine, and we recruited them by paying them a ton of money to get them to show up at these focus groups. So they got a $500 incentive to show up for an hour and talk to us about sort of why they were and were not dispensing medication for opioid use disorder. And these were these focus groups were grounded in the theory of planned behavior, and that we used a very open moderator guide that kind of came from Eisen's original TPB manual. But we really wanted open discussion, and we really wanted to explore some of these other areas. And so we tried to facilitate as much back and forth between the pharmacists as possible. And if you look at a lot of the published literature as to why pharmacists don't dispense buprenorphine, we oftentimes hear it's stigma, and it's time. I don't have enough time to do it. And in the back of my mind, I've always kind of thought it doesn't really take any longer to dispense buprenorphine than another prescription. So I don't think that's just it. But what we heard was really, it is stigma, there is concern, but there is just an overwhelming fear of enforcement. We had pharmacists saying that the DEA came in and they only wanted to look at the buprenorphine prescriptions. And we heard about this wholesale issue over and over and over again. And so when you talk to pharmacists, you end up with a lot more complexity than I think you do through a survey where you've got academics who are sort of defining the areas of inquiry. It's always good to start at the ground and involve the people that are actually making the decisions. And what we found was that there were sort of 9 or 10 key areas that we really needed to work into this practice guidance. The first was employer oversight. All of these pharmacists, particularly our chain pharmacists, mentioned that their employer had policies that prevented them from filling buprenorphine prescriptions. Go get on Google, try to find written policies that prohibit a pharmacist from filling a buprenorphine prescription. You can find one, and it's Walgreens' good faith dispensing policy. And even then, buprenorphine is not listed as a component of that policy, but there's this line in there that other drugs may be added to the GFD protocol based on district manager oversight. And from what we heard from many of these pharmacists, their district manager absolutely required them to do a full GFD check on all buprenorphine prescriptions they were dispensing. Payment. I lose money. That's the problem. Yeah, we got to fix that. I can't fix that with the guideline. I still don't know how to fix that, but yeah, we cannot be losing money on this prescription of all prescriptions. Maintenance. They just don't know how long patients should be on this drug. Well, don't they taper off eventually? How long are they really going to be on it? And it's like, okay, if you have a diabetic that's on metformin, do you look at them and you're like, when are you going to get off of this? No, you don't. And so reassuring pharmacists that this is a chronic disease state that occasionally needs lifetime treatment, very, very important. Monotherapy. Well, they want it without naloxone. Well, how are they paying for it? Well, cash. I don't like that either. Well, it's cheaper. They don't have insurance. So reassuring pharmacists that you have to take care of uninsured patients. So that's an okay thing to do. They don't know how to use the PDMP. There is stigma and a lack of compassion. I think we can begin to address some of that. Communication. It's coming from one of these telehealth companies, and I call and I get a nurse, or I get a clerk that's at the other end of a 1-800 line, and then I get put on hold and they hang up on me and I can't get a hold of the doctor. That's a problem. We need to address communication. A lot of need for early refills in this population. Things happen, medications get lost. A lot of these patients are cutting their buprenorphine strips. When you cut that strip, if it gets exposed to moisture, it's damaged, you got to throw it out. Explaining that to pharmacists is really important. Red flags. Well, the patient lives 40 miles away. That's a red flag. I only fill for patients in my zip code. Sir, you're the only pharmacy in that 40-mile radius that dispenses buprenorphine, right? Wholesale and some of these other barriers. But there's a lot of complexity here that really needed to be addressed in a way that is not traditionally addressed by a clinical practice guideline. And so with sort of after that elicitation phase was completed, we took those responses and arranged them into 14 vignettes that described a unique barrier to buprenorphine supply. We then ran that before a 22-member expert panel with a wealth of experience and different backgrounds. And we had them sort of write recommendations to address the problem described in each of those vignettes through a series of open-ended questions. We then took those recommendations and we distilled them down into 79 unique statements. And we had them vote on those statements, or vote on the appropriateness of those statements through a Delphi process. So in the first round, we were able to accept 63 of those statements, meaning that 70% of our panel viewed them as appropriate. We took the remaining 16, we modified them with feedback that was elicited from the panelists, and we had them vote on them again. 13 of those reached consensus. We took the modified statements that were left, and we went to a live round where we let them discuss the appropriateness of those 3 statements, and we had 1 additional reach consensus, and we discarded 2. Our rate of acceptance was very high compared to most Delphis, and I think that's for 2 reasons. First of all, we were recommending very common sense solutions that were just easy to accept. And then secondly, in addition to that, we allowed panelists to have a lot of feedback across the panel. As somebody who's been on other Delphi panels, I've kind of gotten the vibe that maybe I wasn't the most stringent or heavy-handed facilitator. I've been in some of these now where it's like you kind of got one person that's going to say, no, we're going to go this direction, and then you get cajoled into doing what that person wants. I didn't do that. I let these people make decisions as much as possible. After the draft was completed, we held a public comment period with the National Association of Boards of Pharmacy. They posted it on their website and sent it out to their members. We sent it out to quite publicly through a press release from the University of Houston. And ABP also had a companion press release, and we elicited feedback. We ended up getting several comments from not only individuals, which I kind of expected. I didn't think anybody would care, but we got some. But then we got comments from like ASAM and the AMA and the American Pharmacists Association and ASHP and Vital Strategies, and all of these groups showed interest in this guidance. So we released the final guideline, and then I kind of talked to our funder and I said, I don't know if we should publish this quite yet. We've gotten a lot of interest from some of these groups. I really think that we should maybe ask for their endorsement now that we've addressed their feedback. So we kind of put things on pause, and we went through a series of soliciting endorsements. And that was a really interesting phase, because then these organizations became very interested in not only adopting the guidance, but ensuring that the guidance sort of matched what they would expect from pharmacists in this area. So we had great dialogue with ASAM and great dialogue with APHA and ASHP. And then sort of toward the end, the National Pharmaceutical Association reached out to us and asked if they could provide their endorsement, which we were thrilled to do. And AAPP, the American Association of Psychiatric Pharmacists, all of these agencies really wanted to have a piece of this. And so after we gained those endorsements, we went ahead and released the guidance in September of 2024. And essentially, we offer 9 very common sense recommendations. Keep buprenorphine in stock, recognize that opioid use disorder is a chronic disease, use prescription drug monitoring programs effectively, and think about how to interpret red flags and telehealth prescriptions in a way that serves the patient. And I was telling the guests from Ophelia yesterday that This is a really long document. I acknowledge that. It's 50 some odd pages, but pharmacists love to read. We're very literal people a lot of the time. And, you know, a pharmacist really benefits from very, very tangible information. So a lot of this is scenario based. Say you have a patient who shows up and they say that they've lost their buprenorphine or it was stolen. What do you do? And we kind of walk through that scenario. We talk about how to interpret red flags with very concrete definitions. And that's something that's just not done. You know, there's a document from the State Board of Pharmacy in Texas called "You Might Be a Pill Mill If," and it's ridiculous. I mean, it provides like 3 pages of very, very detailed information about how to interpret red flags. And that is the most detailed red flag document that I think I've ever seen. Other than that, you're wading through DEA case law and you're like, maybe, maybe not. So we wanted to provide sort of the patient-centered version of that story and really think about how these things may actually occur in the course of routine care and give pharmacists another side to interpret as they're making these decisions. So happy to talk about that in more detail later if you'd like. But the other issue that sort of came up after the release of our guideline, or during the creation of our guideline rather, was this issue of buprenorphine wholesale. And I am convinced that this is still one of the most salient barriers to access for patients with opioid use disorder in the community setting. And when we coded our focus groups, we really saw the emergence of several key themes that were related either to payers, to the DEA, or to wholesalers themselves. Each of those barriers sort of had a distribution angle to it. And so we saw this need to not only create guidance for pharmacists, but to really create policy guidance for pharmaceutical distributors. So I'm going to read a couple of these quotes just for sort of emphasis here. But one of the most interesting things is pharmacists are aware that these thresholds exist, but they don't know what their thresholds are. So oftentimes they try to predict them. And so we have this pharmacist that said, we think we get cut off every month when about 20% of our prescriptions are controlled substances. So we stop just short of that. And I'm like, well, have you ever tried to push it? No, we stop right there. We don't dispense more than 20% of our total volume of controlled substances. That's not great for patients that need access to controlled substances, especially if we're prioritizing things like, you know, ADHD medications. We're disenfranchising our patients with substance use disorder when making those rationing decisions. And then enforcement. We had a visit from the DEA, just a random inspection, and they said that buprenorphine was one of the key drugs that they were interested in. So if you look at DEA's public messaging from the federal level, we get a lot of, we know that pharmacists are going to order more buprenorphine in the wake of MAT Act expansion and everything else, and we totally expect them to order more. Distributors should adjust their thresholds. And then you look at the behavior of a DEA field agent, and it's not that. It's, I need to see your buprenorphine records. Right? So how do we reconcile that? And I think the answer is to begin to put some pressure on the DEA to provide guidance to distributors. So this is a manuscript that, it pains me to say it, but it's still under review, where we sort of offer our panel's recommendations to pharmaceutical distributors and to regulators. And we highlight several of those qualitative findings in this manuscript as well, to sort of paint this whole picture that this is a major concern. And what we conclude through making these recommendations to distributors and regulators is that there's not a lot that an individual pharmacist can do here, other than don't try to protect your thresholds, just keep dispensing if you can, and work with your distributor to get a threshold change request. But outside of that, it's really on the DEA and the distributors themselves to come to some sort of solution here to encourage pharmacists to be able to purchase buprenorphine. And DEA can do that non-legislatively. It is within the purview of the injunctive relief for these distributors to adjust their thresholds on their own. All DEA has to do is provide oversight for that process and ultimate agreement to accept those new thresholds. That's it. We don't need a bill. We don't need an act of Congress. We need the DEA and the distributors to sit down together and have that discussion. At the recent annual meeting, the National Association of Boards of Pharmacy passed a resolution to do just that and to sit the distributors down with the DEA and begin to think about buprenorphine wholesale. And so I'm hoping that some of our guidance can continue to guide that discussion, and I hope that we see improvements in buprenorphine access through that process. So now we're focused on disseminating the guidelines. We've had great media coverage, and one of the things that and we've had several CE programs that have come out related to the guidance through our partnership with NCPA. One thing that I'm very excited about, though, is that SAMHSA has agreed to move forward with a companion guidance to pharmacists called Prescribing Medications for Opioid Use Disorder in Pharmacies. This will contain content on the development of collaborative practice agreements for pharmacists to be able to initiate buprenorphine pharmacotherapy in states where they can obtain a DEA registration, which is not the state of Texas. But in addition to that, it will also provide a lot of sort of baseline comment on access to MOUD and that parallels our guidelines. So I'm very excited for that to come out if SAMHSA continues to exist. That's not a joke. And so kind of moving from there, I think it's important to think about how we can bring some of this decision-making into other areas of care. And one of the things that I think is really important to focus on in medication for opioid use disorder is how do we prevent interruptions in access to buprenorphine or other forms of MOUD. And that's incredibly important because, as I mentioned earlier, if we interrupt care, we see dramatic increases in mortality. And as it is now, we see very few patients actually complete a minimum duration of 180 days of pharmacotherapy for opioid use disorder. Most of these disruptions are not voluntary on behalf of the patient, although several of them are. A lot are because the patient loses access to a prescriber, encounters difficulty with payment, or has a change in setting of care where they go from the community to the emergency department, and then all of a sudden their MOUD is cut off, and we're scrambling to figure out what the patient was on before, and it's a nightmare. So I think three key questions to address in this area are: how do we provide collaborative care for patients with OUD across different provider types, including pharmacists? How can we effectively enhance the perceived value of providing care to persons with OUD to incentivize institutions to provide care? And what strategies can we use to improve transitions of care for patients with substance use disorder? And a lot of this comes down to that idea of sort of stopping this revolving door between the community and inpatient institutions in the pharmacy. One of our biggest problems right now is we have a patient that's initiated on buprenorphine in the emergency department. The emergency department is potentially doing that through a grant-funded program. Their outcome in that grant-funded program is successful buprenorphine initiation. Yay, we got him a dose of buprenorphine. Bye. And we send the patient out with a prescription without an effective plan to bridge. Or we have a patient who's on methadone. This is incredibly common and quite tragic. We have a patient on methadone who's well maintained in the community setting. Something happens to them, they're admitted. The doctor has no clue to do with methadone, and all of a sudden the patient is either transitioned off of methadone due to concerns with need for other opioid agonists, or the OTP is closed and it's a Sunday and we can't figure out what that methadone dose is. We can't trust the patient, God forbid, that the patient knows what they're taking, and so we just don't continue methadone. The patient goes into withdrawal. We then maybe try to bridge them with buprenorphine or do something. In either way, we send them back to the community. One more story. I was at ASAM this year, and there were two posters about exactly the same thing, where a patient was receiving methadone from an OTP, had untreated alcohol use disorder, self-reported to an alcohol treatment program, was initiated on naltrexone, pitching them into withdrawal. Then they go to the ED, and they are initiated on buprenorphine to restabilize them. How does that happen? We don't ask questions of our patients. We don't trust our patients. We don't think about the fact that patients might have polysubstance use. We simplify problems because we're not willing to have a dialogue with the patient, and we don't know how to contact an OTP. We don't know anything about methadone. I mean, it's crazy how many providers just overlook this area of care when it's so problematic, particularly for care transitions. And then there's the pharmacy piece, right? We send that patient out from the ED and they just don't know where to go to fill their prescription because the ED pharmacist or the ED physician doesn't even know where the nearest Walgreens is. They just let the page or the scribe handle it, and that's it. And the patient's on their way. Poor communication. So recently I was involved with an initiative from the American Hospital Association and the Centers for Disease Control to really think through transitions of care for patients with substance use disorder. And we sort of agreed that we wanted to focus on 5 key things. We wanted to talk about how to overcome barriers related to a lack of interconnected systems. We wanted to talk about stigma. We wanted to talk about regulatory affairs. And then we also wanted to find new strategies to engage clinical champions that go up to the level of hospital administration, because all levels of the healthcare system have to have a commitment to patients with substance use disorder. And we wanted to provide a clear guide with clear starting points for institutions at sort of all points in their substance use disorder commitment to get them to a level where they are able to provide care. And so we launched into a participatory study with 3 health systems who were selected, and I'll talk about them in a second. They were selected because they were all sort of a different, they had substance use disorder care programs in varying points of success, ranging from incredibly well established to very, very nascent. Each of those health systems contributed subject matter experts from the inpatient, outpatient, pharmacy, administration, apologize for that typo, and administrative settings. And we tasked this panel with identifying opportunities to improve transitions of care for patients with OUD. We met monthly with those health systems, and for the first 2 months, we really focused on designing a new program that each health system could implement to either improve buy-in from clinical champions or to implement a new service line for patients with substance use disorder. And then once we sort of had initial plans, we went into implementation, and these health systems were given funding through the grant to actually implement some of those health programs. From there, we began to sort of revise and evaluate their implementation initiatives following sort of an adapted re-aim framework. I don't think I ever heard that word come up in the AHA-led discussions, but that is certainly what we were doing. And, you know, depending on the evaluation, we would make program changes and then sort of re-implement. We did this for a whole year. And at the end of that year, we began to prepare a implementation toolkit to guide transition of care programs for health systems to not only help them initiate and recognize patients on treatment for substance use disorder in the inpatient setting, but also to help them bridge those patients back to the community or to continue pharmacotherapy upon admission. So this toolkit should be coming out in the next couple of months. It's in final review with CDC. And I think the health systems that we included were very, very interesting and very different. We included Oregon Health and Science University, OHSU, and they have an incredibly well-oiled SUD treatment program in their system in place. And they very much so sort of led a lot of the discourse and helped us really provide guidance to the other health systems that are interested in implementing. Honora Englander was one of their panelists. I mean, she's a wealth of knowledge in this space and a great physician at engaging leadership in health systems. And that was such an important angle in these discussions. They also had an established bridge clinic and an established telebutte program. They were doing great stuff. We also involved the University of Kentucky that had a really good inpatient SUD service line, but had some leakage in the ER and upon discharge to the community. They wanted to continue to develop EMR tools and really think about ways to identify patients who are coming in with previously treated substance use disorder. Then we had Trinity Health, who does not have a square logo, but they are a part of Common Spirit, so I use the Common Spirit logo. And they had a very sort of new SUD service line. They wanted to engage peers in the inpatient setting. And so a lot of our conversations with them really kind of revolved around, okay, well, what can and can't peers do? When do we need to involve nursing staff to sort of protect the workforce efforts of our peers? How do we avoid overburdening our peer navigators? And so we had some interesting conversations around that should trickle into the ultimate toolkit. One of the cool things that came out of this, though, is that these health systems, a lot of them chose to create educational materials to use in their institution. And everything I've ever made as a professor, and most things I've seen professors make, are really, really boring. OHSU came with this incredible guide to buprenorphine to MOUD initiation in the inpatient setting. And they include some really interesting tidbits about sort of myths and facts about opioids and opioid use disorder. And I love it because it's colorful. You know, and if I were to make this, it would be blue and boring and have serif fonts and, you know, prime for readability and whatever, and written at a 3rd grade reading level. This is just real, and it's great. And they went and they hung this up in all of the bathroom stalls at OHSU. So every time a person is in the bathroom, they're going to read about opioid use disorder. And again, it just goes back to normalizing this as a routine part of their clinical workflow. The implementation toolkit that comes out of it highlights several of these pragmatic solutions that, again, I think could only really be invented by people who are providing care, not by me, you know, kind of guessing at what the workforce needs. So this is again part of one of the contributions from OHSU, where they talk about alternative ways to identify patients who are sort of frequent flyers or who are readmitted frequently. So they maintain an independent database of patient information with a patient photo to serve as a photo ID for that patient in case the patient doesn't have a driver's license or has other social needs that are not met. And if you've worked with the unhoused, this is incredibly useful because oftentimes, we might get somebody who's experiencing a homelessness an ID and then they lose it next week. And so if we can keep an eye on who these patients are and allow them to continue access services and identify them, we can confidently use their records and resume care where they left off. OHSU also contributed a ton of knowledge about using the 72-hour rule, the 72-hour rule to continue methadone for patients who are initiated in the outpatient setting. So great tools that have come from real experience. They're going to be in this toolkit, and I'm excited for the potential impact that they'll have in care. Another thing that's going to be in there is we have an entire guide for pharmacists about how to sort of bridge connections between inpatient pharmacists and community pharmacists to make sure that we find a way to resume medication for opioid use disorder upon discharge. And each of the sections, the inpatient, the outpatient, and the pharmacy section, all contain these sort of checklists that pharmacists can work through as an exercise with their pharmacy staff and with administration to make sure that the pharmacy department is delivering the services they can for patients with substance use disorder. And so I think practical tools like this that involve perspective of health systems kind of across the continuum are a very useful way to make sure that we are identifying and addressing care needs. And then one of my favorite lines in there that is adapted from the PharmaUD guideline is that every prescription should be treated as a transition in care. I wrote this line, and but I think it's incredibly useful, and I find myself saying it a lot. But we need to get into this mindset that a pharmacist is a part of a care team who is receiving a patient. They are not filling a prescription; they are receiving a patient. And even if that is just a prescription for lisinopril, there is opportunity for that pharmacist to engage. And another line that I'm really fond of is that every pharmacist is a clinical pharmacist. And so if we think about that as a transition of care, and we think about that pharmacist as providing a service, then we kind of move above and beyond the dispensing role, and we begin to think about what else that pharmacist can do for that patient at that point in time. And finally, I want to talk about patient engagement, because I think that this is the most important part of sort of stakeholder engaged research is engaging the people who will ultimately receive care. So we had a little bit of extra money in the PharmaUD budget, and I rather than lose it, I went to the Foundation for Opioid Response Efforts, and I said, I think we really need to make a patient toolkit. We need a guide for patients to help them advocate for themselves and understand how a pharmacy works. And I was happy to say that they didn't say, send us our money back. They liked the idea, and we moved forward with designing a participatory study to elicit patient perspectives around care at pharmacies, identify barriers, and begin to propose solutions that have worked. So the way that this worked is we had a panel of patients, and we had a panel of really, really smart people. And so we included experts in disability law from the O'Neill Institute at Georgetown University. We included a couple of pharmacists in recovery. We included somebody who worked for the SOTA in the state of Tennessee. And we had just a lot of different perspective here in this expert panel. And we then impaneled a group of 7 patients, 2 from the state of Texas, 5 from the state of Tennessee. These were recruited by Faces and Voices in Recovery through a national effort, but they only turned up patients in 2 states, so it's fine. I still think our results were great. And then we went through a 3-round study where we first sat down with the patients to kind of identify barriers that they encountered at the pharmacy and set the scope. In round 2, we began to have them suggest solutions that have worked, and we ran those proposed solutions by our expert panel, who provided additional input or provided legal and administrative context to their solutions, as you'll see in a little bit. And then in round 3, we brought these materials back to the patients and had them review and edit the content and provide recommendations. So all of this was done through a series of live meetings and focus groups with the patient panel, and I think we got really good results. So in terms of setting the scope, we see a lot of sort of misconceptions in the pharmacy. And one of the patients called out that, every time that they go to fill their prescription, their pharmacist looks at them like all they want to do is get high. And that is a stigmatized perspective where, some of this is coming from the fact that the pharmacist is seeing a person that they know to have problematic substance use, and they just assume that that patient is going to continue in their trajectory of problematic use. One of the patients said that she had to memorize a transcript to talk to the pharmacist. And I'm like, do you have that transcript? Like, we could incorporate that. And she's like, yeah, I do. She literally sent me a 2-page Word document of things that she said to a pharmacist that have worked. That I can't think of a disease state where that's necessary. I was amazed by that. But we did incorporate a lot of those communication cues that she wrote into the toolkit. A lot of them seem to sort of give up their autonomy to their physician, right? So they don't choose their own pharmacy. They ask their doctor, who's going to fill this? Where do I go? And they let their doctor call the shots. I know from some research that we've done with epidemiological data that if a patient really can't choose a pharmacy or use a convenient pharmacy, if they have to go further away, they're less likely to remain adherent to buprenorphine. So this is problematic. One of the points that came up is that there really is no cultural awareness of the culture of addiction in the healthcare workforce. I think we all know this, but having cultural competency training for pharmacists or opportunities for pharmacists to engage with persons with lived experience could be productive. And then finally, there's this idea of wearing your disability status as a badge of honor almost, or leaning into your disability status, and recognizing the rights and empowerment that come from that. And I'd like to recognize that I don't have lived experience with substance use disorder. And so it's difficult for me to talk about this in a way that is respectful and embodies the intent of this point. But I thought it was really important that this patient said that she really felt like she just didn't have any rights when she started her treatment journey. And when she became more able to accept the fact that she was living with a chronic condition, that she was able to then sort of lean into that and recognize that that provided her with a right to treatment. And that right is federally protected and something that we hope to empower patients to embrace. And we plan to do that through the release of a patient bill of rights. This was developed by our colleagues at Georgetown. All of these points are sort of they were originally derived from things that the patients had suggested, but then provided context, legal context, based on actual citation of statute. So a couple of the things that we felt the need to include in here was patients have to be able to say no to extra purchases. We had a very small panel, 7 patients. 3 of them had been told that they had to buy naloxone to fill their buprenorphine prescription. That's illegal. Pharmacists can't do that. We talk about disabilities accommodations, that you cannot be denied care to your disability. And there's information about the ADA on the flip side of this that patients can find. The right to a clear and transparent bill. So many of these patients on this panel said, if I need a bridge prescription, if I need 7 days, they just charge me my monthly copay. So I'm paying $35 for 7 films. That's insane. Also, probably illegal. That's price gouging. Let's talk about that. And then they have a right to know who everybody is in a pharmacy. Many of them said, I have no idea who I'm talking to. Nobody introduces themselves. I've noticed that as a person that's received care in community pharmacies that, I can't tell you how many times I've gone to a Walgreens and the technician hands me my prescription, checks me out, brand new prescription for my kid, and will just say, you have any questions? No. All right, have a good one. Never identifies themselves as a technician. That is the offer to counsel, but I never spoke to a pharmacist. It's problematic. Most recently, I had a technician just bring the prescription up, check me out, and then pick up the scanner, walk to the back, shout the word counsel, scan the pharmacist badge, and return to the register. This is the standard of care, right? And while I am a big proponent of advanced pharmacy practice models, I really am very focused on fixing that. And then we can move on. But we have to move beyond that before anybody trusts a pharmacist to do anything. I understand that that's the organization, they don't have time, whatever, but it's not acceptable. And then finally, we have a troubleshooting guide. These are practical communication tools, things to say to sort of navigate that care environment. And on the back of all of these materials, I'm sorry, I'm gonna, I keep going forward, trying to go back. On the back of all these materials, there's gonna be some contact information for our team, assuming we can continue funding, to provide some direct assistance to patients in those moments. And we hope to eventually involve a peer navigator to do some of that work as well, to help us with some of that work. But what do we really need? So a lot of these pharmacists, or a lot of these patients said, we need peers with us in pharmacies. We had a peer that was in the group, and she said, some of the most fruitful encounters we've had have been in pharmacies. I'd love to find a way to expand some of those programs. I'm like, that's a great idea. And this needs to be an app or an online portal. We need to have a way for patients to reach somebody who can answer their questions and provide technical assistance and support. And so we are waiting for a funding decision from the Texas Opioid Abatement Fund Council now for an intervention called Adopt MOUD. And what we have proposed is that we would distribute this patient toolkit that has all of these materials and these communication tools. There's an informational brochure about kind of how a pharmacy works as well. We're going to distribute that toolkit to buprenorphine prescribers at first in the Austin area. And then when the prescriber issues a prescription for buprenorphine for a new or continuing patient, they provide that toolkit to them. If the prescription is denied, the patient can pick up the phone and call or text or email our implementation team. And we would then connect that patient with a peer navigator who would either help them have a conversation with the pharmacist about filling that prescription and try to help the pharmacist understand the need for access, or we would then, if that doesn't work, we would have the peer help the patient transfer their prescription and then provide continuing support. That peer would be attached to an FQHC, which would then allow them to also bill for care coordination, assuming that patient was receiving services from the FQHC or could be eligible for services in the FQHC. And then from there, our team will then call that pharmacy and say, we understand you denied a buprenorphine prescription, and offer technical assistance to prevent that from happening moving forward. If the pharmacist is or is not receptive, either way, we're going to then send an academic detailer to that pharmacy in person to deliver printed copies of our guidance and other supporting materials to offer our support. We will then keep note of pharmacies that are and are not dispensing buprenorphine and provide that information privately to providers who are interested in providing access to their patients to help them avoid these encounters moving forward. So to conclude, I wouldn't have thought about that intervention really at all without some engagement from patients, right? And through this entire process of talking to pharmacists and talking to physicians and regulators and health systems, and then finally patients, it's become very, very clear that we really have to rethink the way that we create clinical programs and clinical guidance. And I think that's old news to a lot of you in this room, but we have to acknowledge that hypothesis-driven inferential research oftentimes is very limited by the basis of that hypothesis. We are pulling things from literature, and we are building new studies based on literature. And oftentimes we neglect the perspective of real people delivering real health services in the community setting. And if the literature that underlies your hypothesis is flawed because of that bias, then this just stacks up. And we get to this point where academic research divorces itself further and further away from practice. And we see a broader rejection of science. Look at HHS right now. I mean, imagine this happening in the Bush era. Imagine this happening in a time where America was a little more rational. But we lose trust from people in the research process. And part of bringing that trust back is bringing research to people and talking to people and engaging them in the research process as much as possible. And using that experience to guide synthesis and guide inference. I think it's also important to remember that care is a continuum, right? That things don't just end in the emergency department, and that when we develop a service linkage or transition of care program, our outcome cannot be the most proximal outcome. There is immense need to measure things down the road. I don't care if you fill a single buprenorphine prescription. It's important. I want to get you started. I want to know what you're doing in 6 months. And so longitudinal evaluation that considers the entire continuum of care is very important. I think we have to move beyond a publication model of success, right? My whole worth as an academic is defined by two things. How much money have I brought to the university? 3 things. How much indirect have they recaptured from that? And number 3, how many publications do I have, and in what journals are they posted? That doesn't do anything for patients, and it doesn't do anything for providers. I say this a lot. There's 2 types of pharmacists. There are those that attend meetings and read journals, and those that don't. And there's a lot more that don't. Same with physicians. There's a lot of primary care physicians that probably haven't read a journal article in 30 years. Your rural doc isn't picking up JAMA every month, right? So we have to think about ways to reach those components of the workforce, and we need to acknowledge academic effort that goes into that. And then finally, implementation has to be a dialogue. There has to be constant evaluation, constant reconsideration, and constant back and forth between the people that are doing the work and the people that are funding and overseeing the work. It has to be a conversation, and we have to react in our program design as much as possible. With that, I'm happy to take any questions. Thank you.
All right. Well, thank you, Tyler. Before we go to questions in the room, I've got 1 question online and then a comment online I'm going to kind of turn into a question. So Garrett says, our newest barrier is that insurance companies are drilling down to dispensing specifically as listed on the FDA package insert and threatening audits if not followed. Those inserts list administering full tabs or films, dosing recommendations that are no longer relevant in the era of potent synthetic opioids and other things. So any idea on how we can get these package inserts updated so that wholesalers and insurance companies can no longer use them to dictate our dispensing, and maybe corresponding make pharmacists aware of labeling changes that have occurred so that they are able to advocate and make decisions independently?
Yeah, I almost wonder if first of all, I think it's important to remember that recently FDA has requested that buprenorphine manufacturers update their labeling to reflect the need for higher doses of buprenorphine. And I think driving that home as much as possible with pharmacists is important. In addition to that, I think Suboxone recently did update their label. And so that's a positive finding. In terms of fractional doses, probably not allowed to officially say this, but I think if we're thinking about this from a harm reduction perspective, there is a time and place to sort of have a conversation with a patient about how they take their drug. And then, maybe the instructions on the bottle don't actually reflect that perfectly, right? And if you've treated enough patients with substance use disorder, or with opioid use disorder rather, you do sort of recognize that many of those patients are going to modify their dosing on their own. And these are important conversations that need to happen in the clinical setting, although that is sort of, I guess, frowned upon, but we do need to be pragmatic about how we address care. That being said, I think, it's critical to ask for authorization as much as possible and to encourage pharmacists to just not throw away a prior authorization request or DUR request and act like the claim's not paid. Usually we can ask for some sort of override or some sort of, there can be some additional administrative action to get a positive DUR ruling. That's not always guaranteed. But the problem here is that a lot of these products are generic now, and we're not going to see generic manufacturers really push to update their labeling because that is costly. And so there needs to be an advocacy push for FDA to just make a decision and to update labeling on their own. That would be a very new market access mechanism. But if FDA is concerned about the public health purpose here enough to request an update in labeling, then why not go all the way and just make that labeling change on your own?
And one other comment online was, we need this same research related to meds, opioids for chronic pain. And, I'm sure you hear that a lot. I hear that a lot online from patients who are experiencing really negative impacts and ability to get opioids. I tend to think of it as a more prescriber side problem than the bupe problem, but have you thought about trying to address that from a pharmacy perspective? Do you have any existing work in that area?
That's a great question. No, I don't really have any direct existing work in that area, but I have kind of thought of that more recently as of late. I mean, it's getting harder and harder for patients who are well managed on opioids to access opioid medication for chronic pain. And opioid medication is probably not should not be our default option for chronic pain. I think we got to this position largely from that perspective for the longest time. But there are some patients that do benefit from opioid pharmacotherapy, and access for them is important. And so, yeah, I do think that guidance should reflect that. And one thing that we reiterate in our education to pharmacists through some of the other work that we do is there are risks to rapidly discontinuing opioids. There are risks to rapidly discontinuing benzodiazepines. And so, yes, I think there's a tremendous need for guidance that sort of ties this to the balancing act that it is in terms of making a patient-centered decision rather than making a regulatory and administrative decision. I think we should write a grant.
I'm sure there's some folks in the room who are excited to hear about writing grants. And I got my picture off the background. So anybody in the room have questions for Dr. Varisco?
I have a grant related question that you're not going to be able to answer, but probably. So, I totally 100% agree with your philosophy about the inclusion of patients and practitioners who are providing this care and services into the decision-making process. I have received feedback from peer reviewers on, in particular, a recent R21 through NIH that was basically like, we don't agree with your over-reliance in your methodology with your community advisory board. How do you even begin to, you can hear the frustration in my voice.
Yeah.
How do you even begin to overcome that barrier?
Yeah, we may have to have a longer conversation about this. That is an interesting question. So, one of the things that I will say is it's important to have methodology, right? And I didn't talk about that a lot today. I didn't know who was going to be in this room, really. But, we sort of tied everything back to actual methods as much as possible. So, the PharmOUD study was a Delphi study. Our patient panel was a patient participatory design, with clear documentation from other evidence about how to involve patients in the creation of educational documents. And so there was rigor there. And then even the work with the American Hospital Association, they had an implementation toolkit or framework that they were following. Whether or not we followed it as robustly as they initially proposed, I honestly don't know. But we seem to have a process in place, right? I was more of a consultant on that project in full transparency. But so I think tying things back to methodology is really important, and representing rigor, and then really addressing that through your rigor section in your proposal is important. That this is effective and empirical and pragmatic. And in this day and age, I would also sort of cite the general tone, right, and the expectation of HHS to create pragmatic research and talk about that, and that this is aligned with HHS priorities of making sure that our research serves patients. That's what they claim. So,
Thank you.
yeah.
Hi, my name is Sydney Staywars. I'm a fellow here at the University of Pittsburgh with the CLIP Center. So I work a lot with community pharmacists across the state, and Rite Aid's closed here this month. So we lost 15% of community pharmacists in PA. So I'm wondering how you think pharmacy closures, community pharmacy closures, is going to impact some of your recommendations, particularly around, we've been hearing a lot of issues with like quantity limits now that we have pharmacy volume like doubling in some of these community pharmacies.
Yeah.
So there's more patients that are on things like Suboxone and buprenorphine. So I'm just wondering, what you're thinking about that and how that's going to impact some of the things that you're talking about.
Yeah, that's a great question. So I'm going to kind of answer it in two parts. To start, yes, that is going to be a massive problem. There is going to be a deluge of patients from one pharmacy to another pharmacy. And I don't know how they're handling the closure. I don't know if other pharmacies bought Rite Aid records, or if this is just kind of like, buy, but no, they sold the records. Okay. So the pharmacies that bought the records are going to be swarmed. Most practically, there is a need to redistribute patients. Some people are going to have to change pharmacies. It's a really important time to think about partnerships between community pharmacies and buprenorphine prescribers to help them enrich their network. One of the things that we presented but never published, of which there are many in my life, was a study where we essentially looked at physicians who directed all of their patients to one pharmacy versus allowed them to more so choose their own pharmacies, again, using PDMP data. And what we found was that when patients have more pharmacy choice, or more physicians from a practice are using more pharmacies, that those patients tend to be more adherent. If everybody's being funneled into one pharmacy, it's going to be harder for those patients to receive care. And this was, again, pre-injective relief. So there has to be redistribution. But for the pharmacies that are motivated to dispense, one thing that we've found to be very successful is providing some coaching and technical assistance to those pharmacies to help them submit threshold change requests. I'm working with a pharmacy in Missouri right now where they've had threshold change requests denied for several months. And so finally I was like, well, you can send me your dispensing data and I will audit you. And so my team is analyzing their dispensing data and contrasting their ratios with what is sort of proposed in the injunctive relief and saying, look, these patients are fine. They're adherent, they're using single providers. Yes, they dispense a volume of buprenorphine, but that volume is being safely monitored. And so, that's effort intensive, right? And I don't have money to do that right now. I'd love to have some funding to do that. But if you truly are interested in helping, I think connecting them to people who understand or developing an understanding of the regulatory mechanism here and then helping to coach the workforce on that can be very impactful.
We have a hand raised online. Looks like Ugachukwu. If you could please unmute yourself and correct my pronunciation if incorrect.
The pronunciation is correct.
Oh, we aren't hearing you. I'll move on and try you again in a minute. Others in the room.
I had a question about, you mentioned polysubstance use and how we need to have those conversations, but it was making me think about in the community what I normally see for treatment for polysubstance use with Suboxone is gabapentin, which there's a lot of stigma with gabapentin by itself and then especially in combination. So I was wondering, like, how do you suggest like improving that, or is that like addressed in the tool?
We don't directly address gabapentin use in the toolkit. I will say that it's really not well addressed anywhere. I mean, including in TIP 63 and in the ASAM guideline. There is an empirical case, though, to be made here. Gabapentin, I don't know where this came from, that gabapentin was this drug of abuse. And I think there is a lot of moralizing that has gone into that. Oh, it sedates, so it is bad. And but at the end of the day, gabapentin is relatively safe. It is involved in overdoses, but rarely is it a cause of overdoses. And I think just maybe some academic detailing and education on the relative safety of gabapentin compared to the alternative, which is continuing polysubstance use, right, is a viable approach. The other thing that we see, or we're very interested in right now and gearing up for a grant submission on, I'm very interested in patients with dual diagnosed OUD and anxiety who are using benzodiazepines at the time of treatment initiation. And what we found in some commercial claims data is that about 15% of patients with no benzodiazepine use before they start buprenorphine are then prescribed a benzodiazepine. Well, why is that? I mean, we're taking patients who were using benzodiazepines that were purchased illicitly, and we now need to manage benzodiazepine use disorder. We want to do that in a supervised way. Well, that's going to give an insurance company a fit. It's going to give a pharmacist a fit. How do you get those prescriptions filled? But I think reiterating that this is safer than the alternative is very, very important. And if we can bring people under supervised care, they're more likely to live. And isn't that all of our goal, right? Presumably.
All right, seeing no other questions in the room. Oh.
I just want to see. I'm interested actually specifically the transcript and the patient-centered, if you go to a pharmacy and you get this reaction, what you can do to self-advocate. Curiosity, you'd mentioned that there's publications coming up. Is there any access to those things yet, or will that be a public access type thing once, et cetera?
Happy to share draft materials. We are kind of working through final phases of graphic design, but like in the next month or so, they should be fully out and ready to go. But happy to share a draft if you would like. They are designed.
Yeah, sometimes we do veteran suicide prevention stuff, and sometimes we get the question, well, how do I do this or whatnot? I like the idea of sort of saying, well, if this happens, then that. I just kind of see how you tackled it.
Yeah, so the troubleshooting guide is kind of formulated as like a series of cards. So there will be a print version, and then we're hoping for like a web-based version. Again, I need more money to do that, but I think we probably can scrounge around the banana stand, if you will. But these are all very, very brief. And in an ideal world, you'd click into a scenario and have your communication cues on the back. And it would all be very visible up front. And so I think that's going to be an interesting tool. I'm curious to evaluate it and see if it's actually used and effective. But yeah, happy to share.
Thank you.
If the infographic from OHSU is available online.
I can send it to you. It will be in the final toolkit. And if you I don't know if you recall at the bottom, actually I may have cut that off. At the bottom, there's going to be like 3 blank spaces that institutions can plug their own information into. But yeah, they've allowed AHA and CDC to adopt that infographic. So we will provide it ultimately with the full toolkit. I thought it was great though. Very colorful.
Through overdose fatality review programs. that
Mhm.
we're part
Yeah, yeah.
All right, well, this won't be the last that Peru will see of Dr. Varisco. I think we built a nice bridge here between UT and Pitt. But please join me in welcoming and thanking Dr. Varisco for spending the last 2 days with us and for a wonderful seminar.
Thank you all.